The Monona Terrace Wellness Talk, 10 Things to Know About Aging. Twice a year, the Madison Senior Center partners with the Monona Terrace to present a wellness talk geared at adults age 55 plus. The Madison Senior Center is located at 330 West Mifflin Street and offers a gathering place for learning and engagement for all adults age 55 plus. Before I introduce our speaker, I want to introduce you to Samantha Bath from the UW All of Us Research Program. All of Us is our financial sponsor for this presentation. Samantha is going to share information about what All of Us is and why their work is important to older adults. Samantha?
Thanks, Laura. Hi, my name is Samantha, and I'm from the All of Us Research Program at UW, just like Laura said. All of Us is a research program aiming to gather health information from 1 million people across the country to speed up medical research and make sure that people who have been underrepresented in biomedical research in the past are better understood as researchers develop new studies. It's important for your own community to be represented. So we ask some survey questions, we ask for some electronic health data, and we ask for a DNA sample. And that helps researchers understand how lifestyle, environment, and DNA all play a part in different health outcomes. We're partnering with the Madison Senior Center to help people participate in the All of Us research program. So you can catch me there every now and then at the lunchtime. But to join All of Us, you can go to our website, joinallofus.org. It's next to me, next to my shoulder. Or you can just Google All of Us Research Program if you forget the specific web address. But yeah, I am very excited to be here today, and I hope that you all enjoy the program with Dr. Eastman.
Thank you, Samantha, and thank you to All of Us for your sponsorship. Now I am excited to welcome our speaker, Dr. Alexis Eastman. Dr. Eastman is from the UW School of Medicine and Public Health, Division of Geriatrics. She is going to take us on a whirlwind tour of the physiology of aging, learn to identify what is quote unquote normal and what to watch for in the aging process. A handout will be available after the presentation that covers the material in the presentation. The program is also being recorded, and you will be able to access the recording later from either the Monona Terrace or the Madison Senior Center websites. And now a little bit more about Dr. Eastman. Dr. Eastman is a geriatrician at the UW Wisconsin-Madison with clinics for primary care and memory disorder diagnosis associated with the Wisconsin Alzheimer's Institute. She currently serves as the Director of Clinical Operations for the UW Geriatrics Clinics and as the Medical Director for the Badger Prairie Healthcare Center. Additionally, she is actively involved in developing new clinical opportunities for older adults, including preoperative assessment and other forms of comprehensive geriatrics care. Please welcome Dr. Alexis Eastman.
Thank you very much. So it's really a pleasure to be here. I'm really excited to be talking about this. This is one of my favorite things to talk about. This 10 things to know about aging. It is a whirlwind tour. It does go by very quickly. So that is why there is a handout. I will email it to Misty and Karen after the talk, so you don't have to take furious notes. We'll be doing Q&A at the end, so any questions you have, please put them into the Q&A section, and we'll have a little time at the end and we'll go through them all. So I'm going to go ahead and share my screen, and we can get started. All right, so there's the title slide, 10 things to know about aging, whirlwind tour. I think the first thing I really want to impress upon everybody listening is that aging is not a disease. I think they commonly gets treated as such, but it is not. And older does not mean frail, right? Just like soccer is a risk factor for breaking your leg, aging is a risk factor for disease and frailty, but it doesn't have to be that way. So now for the agenda. So we're going to have this whirlwind tour. Thank you for PowerPoint's little whirlwind tornado there. We're going to talk about a concept I want everyone to understand, which is called homeostenosis. And then we're going to talk about the parts of homeostenosis, including movement, the senses, metabolism, the skin, the bowels, the bladder, the mood, and brains and memory. And then we're going to round it off with what I think of as ending on a high note, which is wisdom. So let's talk a little bit about this new word for you, for a lot of us, which is homeostenosis. So some of us may recall back to high school or college biology classes that there's a term called homeostasis. And in geriatrics, we talk about homeostenosis as being the other side of homeostasis. So homeostasis is your body's ability to maintain internal constancy. Really, it's a body in balance. So these are all the different biochemical reactions that sort of keep you in the stable place. So you don't get too hot, you don't get too cold, you get enough sleep, you don't get too thirsty, you don't get too hungry. All of those mechanisms are part of homeostasis. As you get older, many of those mechanisms start to go a little bit awry. So you don't have as much bounce back as you did before. You have a loss of reserves. So challenges are much more overwhelming to your system than they would have been years ago. And that's a normal part of aging. So to put it in sort of a scientific graphical looking picture, if we say that on this chart, the blue line represents your physiologic limit, your functional reserves, and the limit beyond which you cannot bounce back, you cannot restore the internal constancy that is homeostasis. And if we make the red arrow into some sort of stressor, where it's an illness or an injury or major surgery, something like that, if you're younger, that's well within your physiologic reserve, right? So you bounce back pretty fast to the green line at the bottom. But as you get older, the same insult starts to exceed your ability to cope with it. And then the same insult will then mean you don't bounce back, right? Or you don't bounce back nearly as quickly. So what are some examples? So it might take you longer to react to an infection because your body might not be quite prepared to launch a full immune response. At the same time, once that's launched, it's a lot harder to turn that stress signal off. So pain lasts longer, inflammation lasts longer the older you get. It's harder to adapt to changes in temperature. You can't cool yourself off as much. You can't heat yourself up as well. And you have increased sensitivity to changes in position. You may sit up too quickly and get lightheaded, stand up too quickly and get lightheaded. All of these are examples of how your body's ability to maintain homeostasis changes. So how is homeostenosis different than frailty? Well, frailty is what we think of as being end-stage homeostenosis. So all of us get homeostenotic with age, but not everybody gets to this end stage where you are so homeostenotic that you simply cannot cope with any sort of insult to your system. So you have no energy at all. You lose weight without trying. You're weak. You have poor balance and low activity. You just can't bounce back. We can just knock you over with a feather. Why does frailty matter? Well, frailty is very concerning, not just from a quality of life standpoint, but because it increases lots of risks for things that we don't enjoy, such as going to the hospital. No sane person enjoys being hospitalized. Therefore, being frail increases your risk, and we would like to avoid that if at all possible. It increases your risk of disability, of losing your independence, and unfortunately, even of dying early. But frailty is not normal. So while everybody gets homeostenotic, we have less bounce back, less reserve. We don't have to be so homeostenotic that every little thing sends us to the hospital. So let's talk about some of the internal components of what it means to change and become more homeostenotic with age, starting with walking. So walking is really about muscles, bones, and joints. So here's the first slide talking about muscle. And on the left, we have the nice plump muscle of a 30-year-old versus a slightly less robust muscle of an 80-year-old. And that is because muscle declines about 1% per year after the age of 30. That's a fixed number. You can build muscle to lose muscle, but every year over the age of 30, you lose 1% of your muscle. Inside the muscle, there are little tiny organisms called mitochondria that generate the vast majority of the energy in the muscle, and they decrease with age. And the repair of the muscle takes longer. Again, it takes longer to bounce back. That's homeostenosis. Now, because nature abhors a vacuum, when you lose muscle, your body replaces it with fat. So that makes your muscle less efficient. So you have less muscle and it's less efficient muscle. So it makes it harder to maintain the same amount of strength. So you always are constantly sort of trying to counterbalance that inevitable loss of muscle. In the joints, it's interesting. We think of osteoarthritis as normal aging, but it's not actually true. So a normal aging joint has still the cartilage, the material between the bones that kind of keeps it safe and keeps it lubricated and keeps it moving. But the cartilage gets thinner. And inside the cartilage, there's a springy material called collagen. It's a lot like Jell-O. In fact, it is Jell-O. And that collagen becomes stiffer with age, but you have the same amount of it as you've had throughout your life. It's just a lot stiffer and drier. So you've got thin, stiff collagen, which leads to thin, stiff joints. Your joints should be stiff with age. You have fewer repair cells, so again, harder to bounce back. And the tendon and ligaments that can connect your bones to each other and connect your muscles to your bones become less strong. But the bone itself is fine. So what's different about osteoarthritis? So in osteoarthritis, you actually have more cartilage. But it's not very good cartilage. It gets very inflamed, it's overhydrated, it breaks easily. The collagen, the springy stuff in it decreases, it leaks out. You initially get more repair cells in response to this inflammation, but for reasons that we don't really understand, they turn destructive. And that leads to a great deal of inflammation, which causes erosion of the bone below it. So that's not normal aging. So a normal joint should be stiff. It should not be red hot and painful, right? That's not normal aging. Now, the other thing that impacts all of this is the quality of your bone. So it looks a little weird to have pictures of skin and guts on a discussion about bone, but it's all very important. So as you may know, you produce the vast majority of your vitamin D in your skin. Sunlight hits your skin, it creates a reaction that creates vitamin D. And then you can move on using your vitamin D to help you absorb calcium into your body. As you get older, for multiple reasons, you produce less vitamin D in response to sunshine. In some part because people are often getting less sunlight, but also because of changes in the skin that produce less vitamin D. So if you have less vitamin D being produced in your skin, that leads to decreased calcium absorption from your large intestine overall, and your small intestine. So when you have decreased calcium absorption, then your bone has less material to work with. Now, some of that's normal, right? So you should have a little bit less calcium absorption, a little bit less vitamin D, a little bit more bone turnover. So a small decline in bone quality, that's okay. This next slide is going to be talking about how it gets too far out of whack. And this is proving to all of you that I did not go to art school. So I apologize in advance for my poor drawing skills. However, this is my version of what happens in bones with age. So at the bottom, you see a little stretch of bone. Then you've got two types of repair cells in the bone. You've got on the red-hatted guy is the osteoclast, and the green-hatted guy is the osteoblast. Now, every day, just walking around, living your life, you get a little wear and tear in your bones, little cracks across your bones. And the bone repair cells come in, and the osteoclast hollows out the cracks to be filled with new bone. And the osteoblast fills in the hollow with new bone, just like a dentist fills in a cavity. That's normal bone turnover. As you get older, the osteoblasts, the filler in, slow down, but the osteoclasts keep on trucking along. So you get an imbalance of hollowing out to filling in, and your bones get more fragile. When that gets to the extreme end of fragility, you have a disease called osteoporosis. So normally when you're talking to your doctor about osteoporosis or bone density, they say, well, your T-score is blah, blah, blah. And the rest of us go, well, what the heck is a T-score? Well, what is a T-score? The T-score is a comparison of the density of your bones, the hollowing out to filling in ratio of your bones versus a 30-year-old. I remember that I said that muscle starts to go downhill at 30, so does bone. So we always want to compare bone to the perfect bone, the ideal bone, to know how far off from perfect you are. And so it's a measure of your density in standard deviations away from perfect bone. And when you get into the 2.5 standard deviations or lower from perfect bone, we say you have osteoporosis. Now, why do we care? Well, we care because for every standard deviation below normal bone, you double your risk of breaking a hip if you fall over. And then people say to me, well, Alexis, what happens if I don't fall? Well, the truth is that a lot of people fall. So this is data from the CDC, but we know that most people over the age of 65, 1 out of 3 people will fall every year. And once you're over the age of 72 or so, everyone falls every 2 years or so. And once you're over the age of 80, most people fall every year. They don't usually tell me, but they are usually falling about once every year. So falling, breaking a hip, they say, well, I'll just get some rehab, I'll get better. Not true. So falling and hip fractures has a terrifying 1-year mortality rate. So if you fall and break a hip in your 70s and 80s, your 1-year mortality rate is 20%. And there's a 50% chance that you'll never return to your normal state of being. So falling and breaking a hip is a big deal. And the CDC predicts that by 2030, 7 people are going to die every hour from falling. That's crazy, right? That's crazy, especially because it can be prevented. So part of this talk is telling you all the things you don't need a doctor for that you can do to help. And I'm going to pound the same podium over and over again because the single best thing you can do is exercise. Again, stock PowerPoint people, but they're really looking good. They're not going to fall. Regular exercise will decrease your risk of falling by 50%. That is better than any pill I have. Just regular exercise. How much, you ask? 150 minutes every week. You can divvy it up. I don't care how often you do it. You can do 15 minutes 10 times a week. You can do 35 times a week. You can do it in 2-minute increments, whatever works. But 150 minutes every week of exercise will decrease your risk of falling by 50%. Not too shabby. People ask me about what to do with their diet. Well, the truth is that you want to support bone health and you don't want to have to take a lot of pills to do it. So everybody should get plenty of calcium, 1,200 milligrams a day, ideally from your diet. We're in Wisconsin. You can eat the dairy. It's probably illegal to not eat cheese at some point in time in Wisconsin, but you can eat dairy, 300 milligrams of calcium per serving usually, but there's other sources, beans, nuts, green leafy vegetables, figs, a surprisingly good source of calcium. So you can get all of your calcium without dairy if you need to. We also recommend getting protein with every meal. We don't usually eat enough protein as we get older, and so it's nice to just make sure you have some protein with every meal you take. And a lot of people recommend a vitamin D supplement, especially in the winter in Wisconsin, because it is true that even if you dance about naked in the Wisconsin winter, you're probably not going to get enough sunlight to generate vitamin D. But you don't need to do a lot. 25 micrograms, which is 1,000 units a day, is more than sufficient to support your vitamin D needs. You don't need to get the 5,000 unit pills from anywhere. 1,000 a day is fine, 25 micrograms. So let's talk about the senses then, moving from movement to senses, because they all go together. What happens to the aging eyeball? And I apologize to any professional ENTs or ophthalmologists in the audience, because this is my internist understanding of it in advance. So what happens with the aging pupil, which is what lets the light in, is that the size decreases. So less light gets in. So it's less easy to focus. You lose acuity. Can't see those little letters on the eye chart as well, and you need more light to see. At the same time, the eyeball is full of this weird gelatinous material. And in that gelatinous material, you get more glare and halo with age, you get more light scatter. So you need more light, but you get more glare. The parts of the eye that help you focus are all made of muscle, little circular muscles, and that muscle decreases in tone and elasticity. So it gets stiffer and harder to move. So it's much harder to change focus. You bring something from far away to closer to your eyes, it's a lot harder for your eye to adjust. And in the very back of your eyeball are these little rods and cones that help you detect black and white, shades of gray, different colors, and those decline with age. So you have less contrast sensitivity and less color discrimination. So it's much harder to differentiate between subtle tones of red or blue or gray even. It becomes more of a blur of one color. So this is a kind of a poor demonstration of it, but a nice one. You can see on the right-hand side, it's just a little grayer, and on the left-hand side, it's nice and blue, kind of the two different eyes. But you also lose depth perception. Now, this is an optical illusion. All these cacti are technically the same size, but it's a good demonstration of what can happen with an aging eyeball as it starts to lose the perception of depth. You also lose peripheral vision. So where this becomes really concerning and something to keep an eye on is when you're driving. There's no age at which you have to stop driving. You just have to be aware of these things and keep in mind that they can make driving more difficult and more dangerous for you. So how do you preserve your eye? Well, the eye is full of tiny little blood vessels. So the first thing you can do is control all of the health issues that contribute to damaging tiny little blood vessels. And that's really your blood pressure and diabetes. You really got to make sure that those are under control to preserve the tiny little blood vessels in your eyes, in your ears, in your kidneys, and your toes. And most people need a good eye exam every year. Unless you have an eye disease, you don't always need an ophthalmologist. But everyone should see a good optometrist every year to get their eyes examined. You need to have more light in your home, but you want to use warmer colors because they're a little less likely to create that glare and halo effect. So nice, warm, increased light, increased contrast in your home. You want light floors, dark walls, or dark walls, dark floors and light walls, something that helps you see where the edges of everything are. As much as you can, you want to try to avoid driving during particularly dangerous conditions for the aging eye. Twilight, in bad weather, maybe at night, if you have a lot of halo effect, times where there's lots of light, just be cognizant of it. And you want to make sure you're turning your head more or have better mirrors to counterbalance the peripheral vision loss that happens with aging. And make sure you're always wearing your sunglasses in bright light, because while you need more light, you do again need to counterbalance the halo effect. So let's talk about the aging ear. It is shockingly true, not just a myth, that your ears get bigger with age. Nobody knows why, they just do. And they do get more hair in them. Again, a mystery, but it does make it harder to get the earwax out. I spend a lot of time removing wax, and frankly, I think it's very enjoyable, so I'm glad I get to, but it is harder for my patients to deal with their earwax as with age. The tympanic membrane, which is sort of like the head of a drum that responds to sound. Sound comes in, the tympanic membrane vibrates. That becomes stiffer with age, so that creates one type of hearing loss. And then on the inside, in your inner ear, there are these things called hair cells that when the sound comes in, they bend in particular patterns. And that transmits a signal to your brain, which allows you to hear things. With time, with age, with exposure to loud noise, maybe, you know, I think, as my parents say, if you were in the 60s and remember it, you weren't really there, but you were probably at a rock concert of some type, and you may have fewer hair cells because of it. Maybe you had exposure to loud machines in the military or farming, and you lose those hair cells. And so that increases a certain type of hearing loss. In another portion of the ear, the middle ear, is where you control balance. It's a little bit like a carpenter's level. There's these loops full of fluid. They help you maintain your balance in space. But with age, you get little crystals in them called otoliths. And when those otoliths are out of whack, you get vertigo. That's what benign positional vertigo is when you suddenly sit up or lie down or move over and the world starts spinning. It's very disconcerting and very difficult to deal with. And then finally, your ear drains into your sinuses. And those eustachian tubes that drain your ear, they get weaker with age. And so it's more likely you get that fluid buildup. So you sort of feel like you're hearing things from underwater. So all of those affect your hearing, and some of those affect your balance. So what are the things you can do to help your ear? Well, the same things you can do to help your eye. Control the things that will help the blood vessels and the blood flow to your ear. And if you're going to rock concerts now or really loud symphony concerts, the 1812 Overture, for example, avoid excessive noise exposure, wear your earplugs. But also continue to interact, because if you stop listening, the parts of your brain that process sound don't work as well because they've got nothing to do. So don't forget to interact. So to that extent, if you can and you need them, wear your hearing aids. They are the most effective and adjustable treatment there is in the world for hearing loss. And in fact, we think about 9–10% of your Alzheimer's dementia risk is related to untreated hearing loss. So it's also a dementia prevention tool. But only about 10–30% of adults who need them use them, in part because they're really expensive. If you've ever seen the price of hearing aids, it's wildly expensive, and Medicare doesn't cover them. And you can't just pop them in and hear things. You have to adjust and adapt to them. You have to get used to them and change the settings. It's really easy to give up. And some people feel like everyone can see them. So I put the picture of our former queen, the former Queen of England, up just to show that she's wearing a hearing aid and nobody can see it, right? However, it is cost prohibitive for some people. And when it is cost prohibitive, I recommend personal amplification devices. They're not quite as good, but they do work in a pinch and they're much cheaper. We use them in clinic. There's like something called a pocket talker. That's a little headset and a little microphone. You can hand it out at people and like interview them. And that works really well and is much more affordable. So let's switch gears a little bit more about how you interact with your medical care, which is a lot of my patients ask me, why do I get more side effects? And this becomes a discussion about how the body processes medication. And so for that, we have to have two vocab words, pharmacokinetics and pharmacodynamics. So pharmacokinetics is how a medication is processed by the body. And that really involves the liver and the kidney. And pharmacodynamics is how a medication affects the body. And that really deals with how much fat you have and how much water you have and some structural changes in the body that we're going to talk about. So the first in the pharmacokinetics land is your kidney. Kidneys are really important. They filter and excrete medications. But with age, you lose kidney cells. It is inevitable. So by the time you're in your 80s, 30 to 50% of your kidney cells are gone. Now your labs may be stone cold normal. You may have a beautiful creatinine on the panel your physician orders for you. But that just means that your remaining 70% of your kidney cells are working extra hard. Right? So you have to be careful not to get dehydrated or have too many things that happen to them to really hurt them. You just have to take care of the kidney because they get rid of our medications for us. The liver activates and deactivates medications. It breaks medications down. Now, fortunately, you've got lots of extra liver. That's great. The liver you really need the liver and you've got tons of it. But it does slow down with age. It's 25 to 50% slower. So it might take longer for a drug to be deactivated in your system. As we talked about it, this is another somewhat depressing graph about the loss of muscle with age and the increase in fat. But as we know, muscle declines 1% per year after the age of 30, and your body replaces that with fat. How does that affect your drugs? Well, this is pharmacodynamics in action. Many of your medications prefer fat. And so when you have more fat relative to water or relative to muscle, it acts like a sponge. And so the medications get into your body and they soak into the fat. It takes them a little bit longer to start working, but then when you stop them, it takes them a lot longer to get back out. And then you say, well, how do I know which medication is fat soluble? Conveniently, there is an organ in your body which is about 60% fat, and that's your brain. So if any medication has any sort of dizziness, sedation, memory change, any sort of brain side effect listed, and you're an older person, it's much more likely to have an impact on you and last a lot longer because it's a fat-soluble medication. Now, surrounding your brain is this lining called the blood-brain barrier. And in life, the blood-brain barrier is meant to keep out all sorts of toxins and infections and other important things that keep the brain a protected space. As you get older, that barrier gets leakier. So more medications leak in. So not just the fat-soluble ones, but all medications can leak in more easily. And so you get a higher chance of cognitive side effects. So the more impact on the brain of all your medications. So what may be a minor side effect for a younger person is a much bigger deal in an older person. And then there's the pills, right? So the first thing that often happens is something called the prescribing cascade, where you get a side effect from a pill and someone gives you a pill to treat the pill, and you get a side effect from that and you get a pill to treat that side effect. And you just have this endless cascade of pills that treat side effects. And then, as many of us have experienced, pills are tiny and they're hard to break. And we often say, take half of a such and such. We give you weird doses. We say multiple times a day. A lot of complicated pill regimens go on in the world, and it can be very difficult to manage. If you're on more than 6 medications, there's an 85% chance that 2 of them are interacting with each other, and that may or may not be good or bad. So what are some examples? So the first example is a whole class of medication called benzodiazepines. That's things like Ativan, Valium, Xanax, anything that ends in azepam, essentially. So as we said, they're very fat soluble. They stay in your body a lot longer. So a Valium will last 72 hours in an 85-year-old. versus 12 hours in a 25-year-old. They get into your brain much more easily. They increase memory loss. They're very sedating, and they increase your risk of falling and breaking a hip by 50%. So kind of counterbalancing all that wonderful exercise you're doing. There's another class of medications called anticholinergics. They're the bladder medications. They're Benadryl. They're any over-the-counter that has PM in the title, loperamide or Imodium. They get into the brain much more easily. They can cause more confusion, more dizziness. They will dry you out a lot more, dry mouth, dry eyes, constipation, and falls. Now, there is a time and place for every and all medication. They all have side effects, they all have risk. But it's important to keep that in mind and know that all medications are risky, including your supplements, right? Just because it's a natural vitamin or a supplement or an herb doesn't make it safe. You have to know that there are risks in all of these things. So what can you do when you're talking to your doctor? You can say, hey, can you control the symptom without a disease or disease without a pill? The corollary to that, though, is, are you willing to do what it takes to do that? Right? Oftentimes, diabetes can be controlled, for example, with a significant amount of weight loss and daily exercise, sometimes for a couple hours. If you're willing to exercise 3 hours a day and lose 20% of your body weight, you can probably treat your diabetes successfully. But that's pretty hard and has a huge impact on your quality of life. And metformin is a pretty well-tolerated pill. So there's trade-offs there. It's important to always ask, is the pill for a symptom or a disease, or is it a side effect of something else? Can the pill be stopped ever? And can it be decreased ever? And then, because we're giving you a lot of pills and telling you to break them in little tiny bits, and you've got better things to do with your life, what's your organization system? How can it be as easy as possible? You write everything down in a calendar, why not have a pill box? Just do something you don't have to think about all these pills, right? Just keep them organized some other way, because you've got better things to do with your life. So that's medications. So let's move on and talk about something else that people talk to me all the time about, which is, why is my skin so thin and why do I bruise so easily with aging? So what does the normal aging skin look like? Well, the normal aging skin is thinner. The top layer gets thinner, the fat layer underneath shrinks. This is why we get wrinkles. Now, the oldest woman in the world, it was for a while, was a lady in France who was in the 120s or something. And I loved her quote. She always said, I have one wrinkle and I'm sitting on it. So wrinkles, it's all in the eye of the beholder. Underneath that are capillaries, the thin little blood vessels that supply blood to your skin and then at tips of your fingers. They get thin, they get fragile. There's less fat around them. And that's why you bruise. All you have to do is like tap it against a door frame and then just a giant bruise on your hand, because the capillaries are thin and fragile and there's nothing protecting them. You have pigment cells in your skin. That's what gives you whatever color skin you have. They decrease with age or change with age, and the remaining ones get bigger. And that's what leads to age spots. And you can have ones that are dark and big or ones that are light and big. And so you can have age spots in all different colors, but that's what's happening with your skin. Your sweat glands decrease. That makes you dry and itchy. Aging is a dry and itchy process sometimes. And like all things, the repair process slows down. So you get more weird little ditzels, skin tags, little red spots, little things that kind of like itch and get kind of crusty and look a little weird. And you have more difficulty with wound healing. So it's important to have these things checked out on a regular basis, but know that this is a normal process in aging. So what can you do for your skin? Well, fortunately, this is a pretty simple regimen. You need to hydrate. You want to always remain hydrated enough that your urine is clear. It can be yellow, but it should be see-through. It shouldn't be cloudy. You want to lotion up. Skin gets drier, skin gets itchier. The answer is lotion, lotion, lotion. I do not care which lotion, just sun lotion. And you should always wear your sunscreen. It's never too late to prevent additional sun damage to your skin. And if you're still smoking, this is one more reason to stop smoking. You'll breathe better. You'll also have better skin. So you can both live a good quality of life and look good doing it. One of the other common questions I get in clinic relates to bowels. Why am I constipated? It does seem that aging has a certain amount of constipation that goes along with it. But why is that? So the normal aging guts, mostly the colon. In the colon, there's a big wall of muscle that pushes the stool forward and out. And that decreases with age. At the same time, however, you have plenty of surface to absorb water. The job of the colon is to save water so you don't lose water to the outside world. But it does a really good job, maybe too good of a job when you're older. So you suck all that water back in, so your stool gets harder. Interestingly enough, there are a lot of opioid receptors in your guts. So when you take a pain medication at any age, there are opioid receptors in the guts that say, oh, that's an interesting medication. I better slow down and think about that. As you get older, you've got more of those. So you're more likely to have your guts slow down in their movement related to any pain medication you're taking. And then you lose some of the nerves in your colon. So you don't have the sense as well that you need to have a bowel movement, and you get less time from when you feel the urge to go to the time you have to be there. So all of that mixed together, decreased muscle, drier stool, maybe some medication effects, and the decreased sensation that you have to have a bowel movement lead to constipation. It's a chronic problem. And if you're having lots of loose stools all the time, that should trigger a visit to your doctor, because it's actually not part of normal aging. So what can you do to fight constipation? Back to the podium of exercise again, because it is true that a daily walk can equal a daily poop. Very easy thing to do. It really is helpful. If you can't get your guts to move by themselves, you can walk, and your stomach muscles will help your guts move and move everything through. Other tips and tricks. Everybody on opiates needs to be on some sort of daily regimen. I don't care if it's senna, polyethylene glycol, Metamucil, Citracel, I don't care what it is. Everyone needs to be on something if you're on an opiate pain medication. You got to counterbalance the inherent side effects of opiates. Discipline. We are creatures of habit. Try to go at the same time every day. If you try, eventually you'll train your body to have a bowel movement at the same time every day. And if you want to add the fiber and the bowel regimen to your diet naturally, you need to focus on two things. There's two types of fiber in the world. There's soluble fiber, which holds onto water and doesn't let your guts soak it back into the body. And that's any material that forms a gel when you add water to it. Oats, oatmeal, grits, cream of wheat, apples and applesauce, prunes. Again, anything you can add water to and it forms a gel, beans. And then there's insoluble fiber, and that's looks like fiber. It's something stringy, bran, stringy vegetables. That adds bulk to the stool, which helps you sense the need that you have to have a bowel movement. But you can't forget about water, because if you eat all this wonderful fiber, but you don't drink water, it's like you ate a wool sock. And it's just going to sit there in this dry, husky little lump, and that's not going to help your constipation at all. Moving forward just a few inches from the colon is the bladder. And we don't talk about urinary issues enough, because the vast majority of older people undergo the insult of the leaky bladder at some point in time in the aging process. That's why there's an entire aisle of it in the drugstore, right? So what happens to the normal aging bladder that creates the endless insult that is urinary incontinence? Well, like every other part of the body, you have decreased muscle. Different than other parts of the body, though, when you have decreased muscle in the bladder, it starts to spasm more. You don't necessarily feel it, but it will spasm against the valves that hold things closed a little bit more. And those valves that keep everything inside get a little bit weaker. If you were born with a Y chromosome and still have a prostate, the prostate gets bigger with age, and that will squeeze against the little urethra, which is down at the bottom of the bladder, and put pressure on it and make it harder to get your urine out. You'll have a weaker stream, or you may have something that I like to call repeeing syndrome, where you think you're done urinating and you start to walk away, and then no, there's a little bit more to go yet, and you have to come back. One of the strangest insults to the aging brain is that hormone clocks shift, and what tells your body to make or not make urine is controlled by a hormone called ADH, and you make more urine at night when you're older. That seems like a very strange insult to happen to you, but it does. And then there's a little part of the brain called the micturition center, and that's the part of your brain that says, okay, hold it. Okay, now you can go, now you need to go. Kind of the urgency center. And that gets weaker with age. So by the time you get the urge, again, you have less time to get to the bathroom than you did in the past. And all of that is a recipe for incontinence. So what do you do about incontinence? Well, Kegel exercises. So Kegel exercises, you've probably heard about. They're the thing where you kind of flex your pelvic floor as if you're trying to interrupt a stream of urine or hold your urine in. In fact, that's how they sort of train people to do them, is pee, try to stop peeing, pee some more. That's a Kegel feeling, a Kegel exercise. You can be trained in Madison, at least, by physical therapy. There's a pelvic floor clinic that can train you how to do Kegels, but you can also learn off the internet. You can learn on your own. They work for women and men. Anyone can do Kegels and they help. You have to do pretty much 30 to 40 a day, but you can divvy them up. They don't have to be done all at once. You can do them between chapters of a book. You can do them when you're stopped at a red light or during commercial breaks on TV. Or if you're in a really boring conversation and you want to look like you're concentrating, do a couple Kegels. You will look like you're very concentrated on what the person is saying. It's great for really bad dinner parties. If you're still struggling with urinary incontinence, you want to go to the bathroom every 2 to 3 hours, even if you don't have to. Just get ahead of the urine before it gets ahead of you. Drink your water. You want to stay hydrated, but drink it in the morning. Don't get dehydrated, but make sure that you're not giving your body extra stuff to work with when you're sleeping. And then you want to treat your constipation, because constipation presses on the bladder, which creates more irritation and more likely to have spasm and leakage. And you want to decrease your alcohol intake, because alcohol also irritates the bladder, creating more spasm and more leakage. So now, switching out of that, we're going to go back up to the brain and talk about mood. Because I also hear a lot of my patients telling me that they're not feeling their mood is as good as it used to be. And they want to know, am I just getting old, quote unquote. So what is the normal mood of changes that is allowed for aging? Well, the first one is grieving, right? Aging is not easy. People start to die. You lose friends. Grieving is normal. You should grieve. You should feel sad when you lose people you love. It is totally fine to feel uncertain. We live in some very uncertain times right now, and it's absolutely fine to feel uncertain about what that looks like for you and where things are going to go. It's also fine to question your purpose. Maybe you've just retired. Maybe you're thinking about retiring. Maybe you're not sure. What is your role? What is your next stage in life looking like? And at any age, difficulty with change is a normal part. We all struggle with change. We are not great creatures of change, humans. So what I kind of lump this up, this is my term, but I'm fond of it, it's mine, is existential malaise, right? It is fine to have a sort of purposelessness and a wondering what your next part of life is, and to be a little melancholic about that and just question, what are things looking like? So what is not normal? So what's not normal is physical manifestations of depression, which look different when you're older. It may include things like racing thoughts, loss of appetite, being extra grouchy, which is kind of sort of vague and nebulous, but being extra grouchy, vague moving pains across your body, feeling too tired to move, not having any interest in anything you always had interest in. Maybe you stopped playing tennis. Maybe you don't really want to go out and play cards with people. Not being able to concentrate and not being able to sleep. So note that it's not always sad, right? It's a lot of the physical manifestations of a depressed brain and body, because they are intimately and intricately connected. So it's not really about the mood, it's about your whole system being depressed. Well, what's so important about that? Well, because there are things that depression looks like and things that look like depression, and things that we can treat and things we can't. So depression can look like dementia, but depression we can treat, and dementia we can't really. So you want to make sure you deal with anything you can treat rather than worry about having a disease you may or may not have. Sleep apnea can look like dementia, can look like depression. You want to treat that. Thyroid disease, other endocrine imbalances can look like depression or dementia. So you really want to make sure that you get this evaluated and worked up and work on this so that you don't struggle with all of both the depression or the risk of dementia or things looking like dementia. So who gets depression? Well, in general, about 10% of the older population has depression at any given point in time. If you live in an assisted living or a skilled nursing facility, that rate increases. If you're in the hospital, that's a very depressing place. Full speed ahead. Lots of people have depression in the hospital. Many people with chronic diseases, diabetes, Parkinson's, these are very depressing. They can get a lot of depression there. If you've had a stroke or a heart attack, you have a 50% risk of having depression within the first year after having a stroke or a heart attack. So not small, 50%. Well, if you live alone or an isolated person, you have a much greater chance of being depressed. I think one important thing to keep in mind is that older people are at very high risk of suicide. 18% of all suicides in the US are in people over the age of 65. So it's a big deal. So what do we do about it? Well, medications do work. They're about 50 to 55% effective, and you don't always have to stay on them forever. You can try tapering off after a year usually. And if you add therapy to that with medications, it becomes 85% effective, which is pretty good. And then don't forget my favorite podium, which is exercise, because even a few minutes of exercise will help with depression and anxiety. Doesn't matter what kind. In some studies, it works almost as well as therapy and almost as well as medication. So if you add them all together, medications work the fastest, therapy and exercise keep that benefit going. You can do a triple punch against depression and really improve your mood, improve your quality of life, and make sure that you don't look like you're having dementia or other problems. Which then leads into a question I often get, which is my forgetfulness normal? What is a normal aging brain in terms of memory? The normal aging brain should have occasional and temporary memory lapses. That is okay. It is okay to walk into a room and forget why you walked into the room. It is also okay to be like, I know her name is, and then say, it's Laura, right? The tip of the tongue phenomenon. That's okay. What do we see in the normal aging brain? Well, we see that a decline in processing speed, multitasking, and quick recall, right? So everything slows down. You can still do these things, but it's a lot slower. But what should remain the same is your vocabulary and your fund of information. So what I say to my patients is that your brain is like a library. You've spent however many decades shoving facts into your brain in no particular order. So it takes you longer to find them when you need to. But the book should still be there, right? And once the books or the bookshelves start disappearing, then we have a problem. But when I see people in memory clinic, it's not just memory that we're looking at. We call it that for shorthand, but there's many different aspects of cognition in the brain. So when we test someone for memory loss or brain disease, we're testing immediate memory, which is very short, within seconds. Delayed recall, which is not that delayed, it's just within minutes. It's not memories of your childhood. It's just, can you memorize this list and tell it to me again 5 minutes later? Attention, which is repetitive tasks. Visual spatial skills, so identification, copying. Language, repetition, fluency, how easily it is to express things. Executive function, which is this very nebulous category of judgment and navigation and problem solving, and mazes and getting through complicated tasks. And then orientation, who you are, where you are, when you are, is all part of brain function. So when we say the word dementia, we really mean, are there two areas of cognition, any of them, which may be memory or not, that are impaired that impact your day-to-day activities? So the term dementia is really an umbrella. Now, in that umbrella of dementia, Alzheimer's is by far and away the most common dementia. But there's also a vascular dementia, there's also Lewy body dementia, frontotemporal dementia, and alcohol-related dementia, and many, many, many more. If you put a bunch of us in a room, we'll argue it out about whether there's 38 versus 39 versus 42 different kinds of dementia, but there's many of them. But Alzheimer's is the one that we always think about because it is the most common. One of the reasons we have to care is because it is so common. So 1 of 3 older people will die with dementia, even with Alzheimer's, even if they don't die of it. Every 65 seconds, someone in the United States develops Alzheimer's disease. It's the 6th leading cause of death in the United States, and it kills more people annually than breast cancer and prostate cancer combined. So it's a big deal, and we don't talk enough about it. So let's talk about how you can reduce your risk. I cannot make your risk 0. I wish I could. I really wish I could. But you can reduce your risk of developing dementia of any type. There are things you cannot change. You cannot change your age yet. There's no pill for that, right? You can't change your genetics. and you can't change the past, all the things you may have done beforehand. But there's a lot of things you can change now at any age that will decrease your risk going forward. You can change how sedentary you are. You can change your smoking, your alcohol intake, your diabetes control, your blood pressure, your mood, your isolation, your sleep, your hearing. So basically you can change the future, right? And if you look at all of these different risk factors, these add up to about a 35 to 50% modifiable risk profile. So you can change up to half of your risk of developing Alzheimer's by things that you can actually do. Again, back to the same slide. It's a good slide. I like this slide. Exercise, 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 exercise will decrease your risk of Alzheimer's by over 30%. I don't have any pill that will do anything like that. There's nothing out there that will decrease your risk of Alzheimer's as much as regular exercise. What's the best exercise? Well, it should be moderate, which means you should talk and not sing. For your brain health, you want aerobic. For falls prevention, you want strength training. But honestly, at the end of the day, the best exercise you can do is the one you actually will do consistently and regularly. So you just have to get out there and do something. What do you do about your diet? Well, this is a Michael Pollan quote, but it's really quite true. Eat food, not too much, mostly plants. The Mediterranean diet. Right? The Mediterranean diet has the best evidence for risk factors for all the dementias, vascular, Alzheimer's, any of them, along with every other disease, right? And it's mostly vegetables, whole grains, and things that you can buy at the county fair should be very limited to the county fair only, right? It's the most evidence for vascular risk factors. So when people have asked me about the MIND diet, what is the MIND diet? The MIND is the Mediterranean Intervention Neurodegeneration Diet. It's very, very similar to the Mediterranean. It's got some brain healthy foods, some best avoided foods, but it really is a Mediterranean diet with more nuts and berries. So if you want to kind of keep it straight in your own mind, no pun intended, you can eat a Mediterranean diet, a very vegetable-centric diet, and have more nuts and berries, and you've achieved the MIND diet. People then often ask me about brain games. And they say, well, individual games yield individual benefits. You usually get better at the game, but your brain doesn't get better overall. There's an exception to that, which is thinking till it hurts. If we look at people whose brains are 20 years old when they're in their mid-80s, it's because they've spent a lot of time challenging themselves with things that really frustrate them, things they really care about, and they think till it hurts. So then you want to give yourself diverse, challenging, and interesting activities. Like if you really care about the crossword and you got to get it right, by all means do the crossword. If not, don't do it. Go learn another language. Go take up music lessons. Go volunteer with small children. Do something that challenges you, that makes you think, that keeps you on your toes. So when I said that exercise is better than any pill, people are always asking me about supplements. Supplements work great in mice. Great in mice. We can do a lot of things in mice. We are not mice. There are no supplements, none, no supplements proven to help in humans. There are no good scientific studies that show that any supplement helps preserve your brain, unless you have a nutritional deficiency, right? If you have a B12 deficiency, you need a B12 vitamin, right? But taking a supplement will not prevent you from getting dementia. So to go out on a good note, one of the great things about the aging brain is that it really does become wiser. It's not a myth, it is true. Older does mean wiser. When we look anthropologically at what wisdom is a collection of pro-social attitudes, emotional balance, self-understanding, tolerance, empathy, a pragmatic knowledge of life, and effectively dealing with uncertainty. So obviously, a lot of that has to do with knowledge of life, which takes time and experience. So an older brain is the only kind of brain that can be a wiser brain. Right? What happens in the brain physiologically to help with that? Well, the part of your brain that controls emotional regulation is called the limbic cortex. And as you get older, it becomes more mature. But that results in being able to handle emotion more easily, less amygdala activation. So the state of temper more or less lives in the amygdala. So if your amygdala is less active, you're less likely to fly off the handle and be angry. You're more likely to make more emotionally meaningful choices in your life. You're much more able to put things into contextual interpretation, and you have increased emotional resiliency. Getting older is hard, right? People do pass on, you lose people. It's a lot of grieving. An older brain is more resilient to that than a younger brain. Not that it's not hard, but the older brain handles it better. Well, you think to yourself, I'm not feeling very wise today. Can I make myself wiser? And the answer is yes, you can. There are some things you can do that will enhance the inherent changes of an aging brain to make you wiser. One of those is meditation. So daily mindfulness meditation will increase the areas of the brain that are associated with empathy, reflection, compassion, and self-distancing, which are associated then with wise choices and wise actions. Now, I'm not a very good meditator myself, but you can practice perspective taking. You can say, oh, I wonder what it must be like to be in their shoes. And it's very similar. Like meditation, it allows for the self-distancing and compassion that builds a wiser brain. And then finally, you can interact more. The more people you know, the more diverse experiences you have, the more diverse viewpoints you engage in, the wider your frame of reference will be and the more context you can put things into. So you can get wiser, but know that the aging brain sets you up to be wise. So you might as well take advantage of that. One of the other benefits to getting older is not just for ourselves and our quality of life, but for the rest of the world. Older people are really the backbone of our society. In America, they give more money to charity per capita than any other age group. They volunteer more than any other age group. And honestly, they know everything, right? Because if you don't know your history, you're doomed to repeat it. But who's the repository of history? The aging brain, right? Aging people. So it's really important to know that. It's demonstrated, in fact, by an anthropologic concept called the grandparent advantage. And there's a lot of literature on the grandparent advantage, but I like the original literature, which is pointing out the grandparents have been around for about 30,000 years. And that was about the first time we lived long enough as a species to have grandparents, to become grandparents. And right around that time, there was a cultural leap forward. And we think that's because, you know, mom and dad or whoever could be hunting and gathering and grandparents could raise the kids. But we know in modern studies that having a grandparent improves childhood mortality and decreases childhood malnutrition, improves depression rates for both groups, and improves childhood grades. And it doesn't even have to be your grandkid, right? It could be any small person. You could borrow a grandchild. You can have any sort of small being in your life, younger being, doesn't have to be that small, be younger, and it will benefit both groups. So it's really a kind of a cool concept, the grandparent advantage. So now you know, hopefully from this talk, that aging is not a disease. Older is not frail. Aging is about handling change, and older is about possibility. And if I've left you with nothing else, please don't forget to exercise. So this is my grandmother, who is a delightful 96. I love her dearly. All my talks are dedicated to her. And now I think we can run a few minutes extra maybe and take some questions. So I will stop sharing. Thank you.
Okay, we have a few questions here in our Q&A column. One, my 61-year-old husband has tinnitus. Is that age-related? Any suggestions for how to treat it?
A very difficult disease. It can be a certain amount of age-related component to it, but it can be medication-related. And there's a lot about tinnitus that we don't actually understand at all. A good audiologist can give you tips. A lot of the best tips I've seen have really been about training your brain to ignore it, which is a fairly dissatisfying answer. Is it worth it? So I would just say it's hard. Yeah, it's hard, but you'd want to establish with a really good ENT and audiology clinic.
Okay, is low blood pressure a problem for aging as well as high blood pressure? Does it increase risk for problems? If so, what?
Yeah, it's exactly right. So it's interesting. One of the aspects of homeostenosis is that it's not just one way or the other, right? So you're more risk for high blood pressure and low blood pressure. And if your blood pressure gets too, and they can vary wildly in the same day, in the same half hour even, you can go from a blood pressure top number of 180 to 110. And that low number can increase your risk of falling. If it gets below 100, it certainly will increase your risk of falling. It can make you dizzy and lightheaded. So you have to be equally cautious about blood pressure in either direction. Sometimes we let people's blood pressure run just a little bit higher than we would if they were younger because we're so worried about low blood pressure.
Okay. You mentioned that cartilage is basically jello. My mom swears by eating Jell-O to help her joints. Is that helpful?
A very solid maybe. So there was an interesting study in young athletes who took collagen supplements, and it showed that when they then worked out in their young athlete way, they had less damage to their knees after taking collagen supplements. And that's probably the most scientific data we have on collagen. But I think your mom is wise in that if you're going to be trying collagen for this, and I have several patients who swear by it, and I'm not going to knock it, Jell-O is a much cheaper alternative to the collagen supplements they sell at all of the supplement stores. So I think points to your mom.
Is it worthwhile to learn ASL in case your hearing goes?
I don't know if it will help you in terms of hearing loss versus getting a good hearing aid and cochlear implants. Is it worthwhile to learn because there are people with hearing loss out there who would love to talk to you? Probably. It's a great way to challenge your brain to learn a new language. And it would open up a world of communication to a group of people that are often underrepresented and underappreciated.
What about super agers? Those over 80 years old who act and behave like a person 20 to 30 years younger.
Yeah, we're studying them. One of my colleagues, Ozioma Okonkwo, has a great study going on about the super agers, trying to figure out why. You know, it has to be more than just thinking till it hurts. So that's a source of great and ongoing research. I'd love to know why. But if you are one, carry on. Don't stop.
Another question. I have been told to drink a glass of water before going to sleep to avoid a heart attack. What do you advise?
Well, that's a new one on me. I like telling my patients to drink a glass of water first thing when they get up in the morning so they don't get dizzy. Drinking water at bedtime is not going to hurt you, except when you get annoyed that you have to get up to pee at night. It may help you if you have overnight issues with dehydration or your blood pressure drops overnight. And so it may be specific to you and your health. But there's nothing dangerous about drinking a glass of water other than the peeing issue. But I usually tell my patients to drink one in the morning.
Okay. Many of your recommendations include drinking enough water. My doc said I need to be sure to drink electrolytes in order to absorb the water I drink. Is that a common need for others to keep in mind?
Can be. I mean, you have to drink a lot of water for it to really throw off your electrolytes. But the easiest way to make sure you're getting enough electrolytes is you don't have to drink them all. It doesn't have to be like Gatorade or anything like that, because Gatorade has a lot of salt in it, like 500 milligrams per serving. You could just have a cracker, right? You don't have to get your electrolytes in liquid form. You could have a snack, and that would be just fine.
Okay, thank you. Are artichokes good for the liver, liver and bile production? I think that was a typo.
You know, I don't know that answer. I honestly don't know. They certainly are not bad for you.
And they taste good.
And they taste good. That's true.
So there are no studies that show supplements help humans. Is that because the studies haven't been done, or because the studies actually show that supplements don't help?
The answer is both, right? There's a lot of supplements that are not studied at all. But there are many that have been studied that have been shown to be completely ineffective in humans, while they work, again, amazingly well in mice.
What is a recommendation for optimal protein intake?
A source of great debate. I like to recommend that my patients aim for about 20 grams of protein per meal. That's hard to do. And it's one of those things where if you put 5 doctors in a room, you'll get 7 opinions. So the safest thing to say is you want some protein with every meal. If you're going to be undergoing something major like a big surgery, you really want to bump up your protein intake so that you heal better. And then I would really aim for 20 grams at each meal going forward. But anywhere in there in the 10 to 20 range with a meal is good.
How do you know if lack of energy is normal?
You don't, unless you get it worked up, and then everything turns out to be negative.
Let's see. We have a few questions about how they can access the presentation later.
And I think the easiest way, because it is a really like megabyte heavy presentation, is I will make sure that the handout, which is a text-based version of the whole thing, it's sort of almost me like dictating to you, is available so that you guys can have it in paper form.
I read that tinnitus is related to eustachian tubes being clogged. How do you unclog them?
It can be. Usually the most common way of unclogging a eustachian tube is talking to your doctor about getting certain types of nasal sprays that open it up from the nose side of things. There are other ways of doing this, but that's the most common place to start.
What age should a person have a gerontologist as their main doctor?
Source of great debate. Technically, I think Medicare prefers that you be over the age of 60, 65, somewhere in there. But I think there are some people who feel pretty old on the inside when they're younger than 60, and some people who aren't particularly old on the inside even when they're 90. So it's a little bit of nebulous. What I'm trained to do is to take care of complicated and frail older patients. But I have many patients in my practice who are neither complicated nor frail, and I love seeing them just as much as I love seeing anybody else. So generally older people, but there's no hard and fast rules there.
Does sunscreen affect absorption of vitamin D from the sun?
Yes, it does. Fortunately, you don't need a ton of exposed skin for very long to make it vitamin D. You do need more as you get older. But the benefits of sunscreen do, to the vast majority of the time, outweigh the risks of losing a little vitamin D.
So there have been a number of comments about how wonderful the presentation was.
Oh, thank you.
One of them also adds on that they're wondering about how much the quality of the grandparent-grandchild relationship is based on physical location.
You know, I'm incredibly biased because my grandmother lives in Ohio, and I feel that we have a very close relationship and have for the extent of my entire life. I would give her full credit that I am a happier and better adjusted human being because she exists and we talk. I don't have to be that close to her. So I think talking is a big part of it. I just listened to an article about people leaving each other voicemails, and I thought, well, that's sweet. Maybe I'll start leaving Grandma just some voicemails that we can listen. I've saved every voicemail she's ever sent me. So I think that just making sure that you hear each other and talk to each other, maybe get together for once a year and do a StoryCorps interview, something like that. Meaningful experiences whenever they happen are probably more important than frequency of lesser experiences.
Okay. Since Jell-O was mentioned, does it fit somewhere in the food pyramid?
I've never seen one that includes Jell-O. That's funny. That's a good question. I will have to bring that up to the USDA. I don't know where Jell-O fits in there.
So let's see. Well, we'll see if we can get through a few more here.
Okay.
My mom is 82, and I'm noticing a fair amount of memory loss in the last 9 months. Forgets things said even an hour ago. Who should I have her see?
So I think you should always start with the primary care physician provider to make sure you rule out things like sleep apnea or thyroid disease or depression or things that mimic a memory disease. And then once those are ruled out, then have them come to the memory clinic. Have her come to the memory clinic if she's in town, or there's memory clinics all over the state of Wisconsin. Have her see someone who can formally test her memory if the workup is completely negative at the primary care office.
I know we talked about tinnitus in one of the first questions, but we've had a couple more questions as far as any advice about tinnitus.
Yeah, tinnitus is so hard. I would say that you really have to seek out expert help for bothersome tinnitus. You really need to see an ENT and an audiologist and really work through that, because it's hard, man. It's just a really hard disease.
Is there any way to reduce cholesterol without taking a statin?
It's back to the exercise thing. Eat lots of fiber, high fiber diets, and lots of exercise.
Let's see. Any suggestions for someone who sleeps a lot? Someone who is 83 years young.
Someone who sleeps a lot and is 83 years young. Get evaluated by the sleep clinic. Make sure your sleep quality is good, because if you have poor sleep quality, you're going to sleep more, especially during the day, to make up for the poor quality sleep you got at night.
Okay, we'll do one more question, I think, and hopefully we've hit on most people's topics. My mother developed sensitivity to sunscreen when she turned about 80. She could no longer use it because she would experience massive bruising in her skin and very painful bones. She thinks it started with Epidex, perhaps overdosing. Does any of this make sense to you? And should I worry about developing a similar issue?
That's a good question. I have long ago learned that all potential side effects make sense to me, because no one gave my patients the textbook on human physiology and said, here, follow this. So I have a wide open sense of what can possibly happen to people. And I'm sorry for your mom. I would say hopefully she has good sunscreen. There's lots of sunscreen clothing now that is better than any lotion you could put on your skin. I don't think it sounds like you would have to worry about a similar issue in yourself, but it's something to keep an eye on, and make sure that you stay, maybe cover up with clothing, preferentially to sunscreen if you can.
Yeah. And I know I said that was the last one, but I just see one that I think is really important. Okay. How important is working on balance as one ages?
Incredibly important. Incredibly important. So, strength training is a part of balance training, but you want to make sure you have a mix of different activities, right? So you build muscle, and all the little tiny muscles that control balance really help prevent falls. So you want to make sure you do your strength training and balance training as kind of together, and then your aerobic exercise on other times.
All right, that was our last question. I really apologize for anyone who didn't get their question answered. I know we answered a lot of them. Anything that you'd like to close with, Dr. Eastman?
No, I mean, I just want to keep in mind that aging is really not a disease, right? So you would just really want to move forward and age joyfully, because you can.
Thank you to everybody who tuned in today. This presentation is brought to you by the Monona Terrace, the Madison Senior Center, and All of Us Research Program.